Well, hello and welcome to this Medscape update. My name is Dr. Mark Alberts. I'm Chief of Neurology at Hartford Hospital and a vascular neurologist. And today I'm joined by my friend and colleague, Dr. Jesse Weinberger. I'm going to let Dr. Weinberger introduce himself now. Jesse?
Thanks. So I'm Jesse Weinberger, and I'm a stroke neurologist at Mount Sinai, and where you're seeing me is in the neurovascular lab. I'm the director of the neurovascular laboratory at Mount Sinai.
So welcome, Jesse. What we're going to be talking about for the next little while is something that I'm sure many of our colleagues on the Medscape platform are interested about, and that's the association between COVID infections and cerebral vascular disease. Here at Hartford, we have seen our fair share of COVID folks with strokes, and I'm sure Jesse, being at Mount Sinai, at sort of ground zero in New York, has also seen his fair share. So we're just going to talk about our experience, the types of patients, how we've treated them, and the overall landscape of COVID-associated strokes. So Jesse, since I'm sure you've seen tons of these patients, could you just share with us or share with folks what you've seen in terms of the epidemiology and some of the numbers, and then we're going to talk about specific stroke syndromes. So Jesse, can you give us a broad landscape here about the numbers?
So Mount Sinai isn't just the main campus where the medical school is located. We have affiliates in all over Manhattan and in Queens, and our Queens affiliates, Elmhurst and Mount Sinai Queens, were in the bullseye of the epicenter of stroke in New York. If you recall from the news, Elmhurst was the hospital that got flooded over, and we got a lot of their transfers. So most of the, and we have one interventional team that services all the hospitals. The interventionist moves rather than the patient moving, and that makes it much faster to get a thrombectomy time than waiting for the patient to come to the tertiary center. So in our whole group, we've probably seen the most stroke COVID patients because we've had the most COVID patients.
Sure.
And so just in terms of epidemiology, one of the papers that the interventional group was putting together was in comparison of 1 month of number of interventions compared to the usual month, and they had twice as many interventions for large vessel thrombosis as usual, and over 50% of those patients were COVID patients. So, and these were mainly young patients that were forming clot in the arteries with no evidence of dissection, no evidence of cardiac source, just spontaneous thrombus affecting large cerebral vessels like the middle cerebral artery, and doubling the number of thrombectomies that are usually performed.
So that's a great observation. And one of the things that we've seen here at Hartford, and I want to see if your experience in New York has been the same, is that in general, we have seen a decline in terms of routine stroke patients and even just routine interventions, use of TPA and endovascular therapy. And I think our colleagues around the country have also seen a general decline in stroke patients overall, even though as I've seen and as you just pointed out, in those COVID patients, certainly there seems to be some coagulation and ischemic issues, and we're going to talk about mechanism in a second. But have you tended to see an overall decline in the non-COVID stroke population?
Not so much a decline as that they're coming in a day or two after. They're not coming in for the acute intervention, which is unfortunate because some of them might have been candidates for TPA or thrombectomy, and they come in too late.
Very interesting. And what about the age of the patients that you're tending to see with COVID and stroke? You implied a few minutes ago that they tend to be a younger population, even though COVID, is attacking people at different age groups, and especially very high mortality with the older age groups and folks in a nursing home. How about the stroke epidemiology?
These are patients primarily under 50. They're young patients that are getting this.
Interesting. Yeah, so as we both know, there's been several articles written both here and internationally about COVID causing somewhat of a hypercoagulable state. And we've certainly seen a lot of folks with high D-dimers, DVT, PE, as well as ischemic stroke. Has that been your experience in New York, Jesse?
Well, we see a lot with elevated D-dimers, but some of the patients that had acute thrombus in the carotid bifurcation, we had 4 of those, and 2 of them had normal D-dimers, so we weren't sure exactly why that happened. Some of the patients have had anticardiolipin antibody, and my rheumatology colleagues say that they're seeing a lot of rheumatologic disease mimics from the COVID infection, for instance, Kawasaki syndrome. And so it may be that they're having an immune response that mimics lupus anticoagulant or anticardiolipin antibody as well to contribute to the thrombosis.
Very, very interesting. Yeah, so now as we talk about specific stroke syndromes, we here, I would say, have seen sort of 2 varieties. Number one are folks with MRIs that show a bunch of small strokes all over the place. Like you could see is somebody hypercoagulable with cancer or with a central embolic source, a bunch of small lesions. And then we're also seeing the same thing that you described, which is large vessel strokes like M1 occlusions in folks who don't have a good reason for it. I mean, there's no AFib. They're not really atheropathic per se. They're just having in situ clots. Are you seeing the same variety, Jesse?
Yeah, in addition to the ones that I mentioned with the large vessel thrombosis, we're seeing many with multiple small infarcts, but we're not certain that we don't find anything in the heart that's causing it. And we think it's probably multiple angiopathy from the COVID thrombosis.
Interesting. Yeah, I think in the vascular studies that we've done here in the folks with strokes all over the place, I don't think we've seen a whole lot of folks with what looks like an underlying vasculopathy, looks like irregular vessels. The vessels, as near we can tell, look normal. They're just having clots all over the place, producing this sort of shotgun image of small strokes in different vascular territories.
Right. Well, we're seeing the same thing, but it just seemed to us that it was direct thrombosis in these vessels rather than a shower of emboli.
Yeah, and they could be both, right? I mean,
right.
It's hard to tell. But I agree, we're not seeing any obvious central embolic source like clots in the LV or LA or myxomas or anything.
No. And our echocardiographers didn't want to do echoes on the COVID patients. So
Sure.
Fortunately, the first one we sent to them actually had an atrioseptal defect. So after that, they acquiesced to doing all our studies, and no one else had any positive findings.
But, we and others are seeing folks with DVTs and PEs, which speaks to a hypercoagulable state, obviously.
Right. The people I'm thinking of that had the multiple infarcts, they also had PEs.
Interesting.
Yeah. But no PFOs, so it wasn't a paradoxical embolus.
Mm-hmm. Right. And again, when you have D-dimers in the thousands, it's not too surprising that we would see that. How about your approach to treatment, Jesse, in terms of IV lytic therapy versus endovascular therapy? And I know some of this is dictated by the underlying CTA results, but are most of your patients being treated with TPA or endovascular or both?
We approach it the same way as any other stroke patient. If they're in the window for TPA, we'll give it and then proceed to the thrombectomy if they need it.
Right.
We've had a couple of patients that actually got better right after the TPA, which was nice.
Yes, very, very gratifying. How about the response to endovascular therapy? Are you able to do a thrombectomy or otherwise open up these vessels, or do some of them look like the clot is old and it's like a brick?
No, they mainly open with thrombectomy, but the results are a little bit mixed. I don't think we see the same percentage of recoveries with these patients as we do with under normal circumstances.
Yeah, we're tending to see that most of these clots are removable or otherwise treatable, which to me speaks to the fact that they're probably acute, not like an old clot that's been sitting in the heart for months and then embolizes and is sort of hard as a rock and you have a hard time getting it out.
Right. And that's probably why they responded to TPA as well.
Right, fresh clots and stuff. Now, you did mention that the overall recovery was not as good as you were hoping for. Can you shed some light on that or expand on that?
Yeah. I can't really, it's just observation from a few patients, but it seems like they don't do as well.
So if your patients are like my patients, most of them are not on the primary neurology or stroke service. We're seeing them as consults because they're in the MICU or another ICU service because of their underlying COVID infection. Is that your experience also?
No, we're admitting them to the neurology ICU or to the stroke service floor. And so we're taking care of the COVID patients for primary care as well.
Interesting. Yeah. So do you think they differ in any way from the COVID patients with stroke as a complication versus somebody comes in with a stroke and then you find that they have COVID?
So interestingly, many of the patients, when they go for CT angiography, they're not diagnosed with COVID, and we pick it up as having a ground glass appearance in the lungs, and then we get to swab them. But once we see that, we assign them to the COVID floor until proven otherwise.
Right.
And they're all positive, you know.
Sure. Yeah. My rule of thumb nowadays is that anybody who comes in with a stroke has COVID until proven otherwise.
Right.
And then on the back end, are you having luck sending these folks to rehab or nursing home? What is the paradigm like in the New York City area?
Actually, there are several nursing homes that take them for subacute rehabilitation. Our acute rehab service isn't taking them, but they're going to subacute.
Got it. Yeah, I think we're fortunate because we've had a number of these patients who actually make a good recovery, and the nursing homes and rehab places, as long as they know that their COVID status, they're willing to take them and they're able to take them so that we can offload some of that some of the patients from the hospital to make room for the next batch of patients, right?
Right. Although actually this last couple of weeks that I've been on, it's really been slowing down. We haven't had a COVID stroke patient in a couple of weeks.
Wow.
Mitigation.
Mitigation is good.
The overall number of COVID patients admitted to the sinus system is going down, and also the strokes. The other thing is that as soon as somebody's diagnosed with COVID now, they're being anticoagulated with Lovenox because of the known thrombosis. So all the patients that are diagnosed early with COVID are getting treated with Lovenox.
Yeah, that's a great point, Jesse. We too have a hospital policy that anybody admitted with COVID gets at least prophylactic doses of an anticoagulant. And then obviously if they have ongoing thrombosis, then they will get therapeutic doses.
Correct. But the ones that we were seeing early that were reported, the stroke was the first symptom that they had anything wrong, and the COVID was found secondarily.
Yeah, we're also seeing a lot of folks who come in with sort of an encephalopathic picture, but then when you do the MRI scan, they sort of have the strokes all over the place. So even though they're non-focal, they present as being encephalopathic, but it's strokes.
Most of the ones that we're seeing with behavioral disorder and encephalopathy with the COVID are not having strokes on the MRI, though. Some, but not a lot.
What about the lack of taste and smell? Are you seeing that in a lot of your patients?
I haven't noticed that, but frankly, I probably didn't ask about it.
Yeah, obviously if they're really sick with a stroke or if they're intubated. But I mean, that's been reported by CDC, and it's one of the cardinal screening tests is asking them for a lack of smell and taste, which would imply which would imply cranial nerve involvement, right?
Right. Yeah, going up the olfactory nerve into the brain.
Right. We'll have to see how that evolves. Most of the LPs I've seen have been pretty unremarkable or relatively non-specific. I don't know if you're LPing your patients routinely.
Not often.
Okay.
Well,
yeah.
Most of them are on the Lovenox, so we can't.
Yeah, so you wouldn't be doing that very much. Any other points you want to make, Jesse, about your experience in New York or the patients that you're seeing?
No, that's really the astonishing thing was that these people were coming with large strokes. They were young and they hadn't been diagnosed with COVID, that this was their presenting symptom. But it seems to be abating now. Hopefully that'll persist.
I think here in Connecticut, we're a few weeks behind you in terms of the curve, or maybe in front of you, depending on how you look at it. But like you, we have a number of different hospitals throughout the state. And St. Vincent's, which is in the western part of Connecticut, in Fairfield County, they're still seeing high volumes, but they are all coming down, which is very encouraging.
Yeah. That's, the question is whether it'll stay coming down when we start trying to open up the city again.
Right, I think that's one question. And the other interesting thing that I don't have any answers or insights is to see if there might be some sort of post-COVID syndrome, like, pulmonary fibrosis or some other systemic manifestations after the infection, because you mentioned the autoimmune component. Like many autoimmune diseases, they do have the potential to fluctuate. And it's just going to be very interesting to have these patients followed long-term, 3 months, 6 months, a year, just to see if there are any long-term sequelae, either autoimmune or post-infectious or something in that realm. I don't have any answers or insights, but that's why they call it novel. This is a new disease that we don't have much experience with.
Correct.
Yeah. So, well, I think we've touched on a lot of the points about epidemiology, acute treatment, long-term outcomes. So let me thank our Medscape audience for joining us. So I hope you found this useful and informative in terms of a COVID update with a focus on cerebral vascular disease. I wish all of our colleagues that they be well and stay well, and that their patients have a rapid recovery. Let me thank Dr. Weinberger from Mount Sinai in New York for taking some time out of his very busy day to join us. And again, thank you all very much and be well.
Okay, thanks for inviting me. It's a pleasure talking to you.
Thanks, Jesse. Same here.